Good morning, good afternoon, everyone. Thank you so much for joining us for our first ASCP, American Society for Cytopathology, Cytology Echo. As you know, if you've been participating, we have been doing pathology echoes for several years. We were very excited to collaborate with Dr. Lowe and Dr. Lomo from the American Society for Cytopathology to add this series. If you have any questions during the session, you can put those in the Q&A with the box at the bottom. If you're having a technical problem, you can put that in the chat and we'll try to assist you. These sessions are recorded and will be available on demand on the ASCP website in perpetuity. So you're welcome to look at them at any time if you get knocked off. So don't worry if you have a bad internet connection today. I'm going to turn it over to Dr. Lowe, who is going to run our echo today. Thank you, Dr. Lowe.
Hi, yes, great. Good to see you all and have you all here in the session. We are going to have three components to today's echo. The first will be a 10-minute didactic, and then we will have two case presentations. So the 10-minute didactic will be given by Dr. Frida Rosenblum. She was born and raised in Quito, Ecuador, in South America, where she completed her medical school before coming to the United States for her anatomic and clinical pathology residency at Bay State Medical Center in Massachusetts. She then completed 3 fellowships in surgical pathology, cytopathology, and hematopathology. So she's highly educated here and is faculty now at the University of Alabama at Birmingham, where she's been faculty for 8 years and currently an associate professor and director of the Cytopathology Fellowship. So I will hand it to her now. Thank you.
Thank you, and good morning, good afternoon to everyone. Let's start with my share screen. Let me get that up and running. Oops, there we go. All right, so let's start with using cytology for microbiology. And there's nothing more exciting to me than cytology, so I hope you feel the love that I have for this specialty. So the outline of this talk is just 2 major points: how to allocate cytology specimens for microbiology testing, and then some microbiology tips. And of course, no conflict of interest to declare. I wish sometimes I had it, but I don't. I'm not that special. Anyways, so when I was preparing this talk, I did a little literature review, as everyone does. And I found this amazing article from 24 years ago. It's so good, but it started with a little bit of history of using cytopathology in the microbiology setting. And I found it fascinating that probably the first report that uses fine needle aspiration and diagnosis of infectious disease was from 1904. I mean, so long ago. And in this study, they used FNAs of lymph nodes to diagnose trypanosomes. And I thought that was fascinating. And of course, a lot has happened in that time frame. And then Memorial and Sloan Kettering actually went on to kind of progress using cytology for the diagnosis of infectious disease. So, as you all know, cytology specimens are divided into exfoliative cytology and then fine needle aspirates. And the fine needle aspirates can be done superficially or deep, right? And the ones that are deep are the ones that use radiology usually or endoscopy to get to that sample in that specimen. And all of you know all these different types of samples. And knowing this kind of helps you because what you're going to do with a sample matters later. All right. And so, but the perspective is completely different. So if you ask me, what I want from the sample is a good sample so I can diagnose it, right? And then allocate it for possibly ancillary studies, whether that's immunohistochemistry or molecular studies. However, if you ask our microbiologist, Dr. Sixto, he's like, no. What I want is a good specimen that I can isolate, ID, classify, and test for susceptibility of all these microorganisms. So clinically, what's really, really relevant and important is, are you considering an infectious process in your differential diagnosis? Because how you allocate the sample then matters. The other option is, if you have no idea, you take 2 samples, one for me, one for him, and we share, and we're all happy. The other option is the microbiology lab can take that sample and then give me a portion. And why is it important that it goes to them first? Because they can do it sterilely, aseptically. So that also matters if you're going to share a sample. All right, so I found an article from 2018 from Dr. Syed Ali that also talked about cytology and infectious organisms. It's a wonderful, wonderful article, but remember that this is based in the US, and we do have geographic differences when we're thinking about infectious disease and our differential diagnosis. But focusing on this, I thought it was really cool to bring it back to what we do all the time. So in every single cytology specimen, we could potentially have an infectious process and an infectious diagnosis. So I plugged it in because it's important to recognize the common organisms that we can see by location. And that having that in mind also keeps your differential diagnosis kind of a bit organized. And I like having everything in a little bucket that can keep my brain organized and I can remember to test for. And there are ancillary tests for detection. And the thing that has progressed, or the category that has progressed the most, is GYN cytology. As you all know, molecular testing in GYN cytology is big for infectious organisms, particularly for HPV. So that's super, super important. All right, and then again, these are some of the pictures that I have taken over the years from some of my cases, but I just want you to remember that based on the location of the specimen, you will have a differential diagnosis for common organisms. But there's always a pitfall, right? So for example, if we're thinking BK polyoma virus in the urine, you have to remember that it can mimic high grade. So again, I think that's why this table is so important, and that's why I plugged it in, but not to go over every detail in the table. All right, now, if we go back to basic cytology, then of course there are basic and routine stains that we commonly use. Not just for diagnostic purposes like the Papa-Nicolau and Diff-Quick stains, or even the H&E for the cell blocks, but also for different organisms. Here in the United States, the ones that we use commonly are GMS for fungal organisms, PAS for fungal organisms, AFB, and PHYTE. The bacterial stains, not as much. We take advantage of the fact that we have the microbiology lab and that we do have immunohistochemical stains for them, but it's still important to know, because if I go back to Ecuador, my home country, I don't have all the advances, all the technological advances, and I might need to go back to basics. And that's why this table is still really important to me, because I can still make a lot of diagnosis, a lot of clinical impact for my patients without going all like super molecular or super fancy. All right, now, again, if we're thinking about the cytomorphology and ancillary studies of common organisms, I plugged this table also from Dr. Syed Ali here. And what I found fascinating about this table is not just all the possible bacteria or acid-fast bacteria or organisms that are important to recognize, but the fact that most of them don't really have something that we perform routinely. We still have to think of them in the clinical context and just basic special stains. And those basic special stains haven't changed, you know, in years and years and years. So even though molecular has been developed for a lot of stuff, we don't routinely use it for everything. We use it for acid-fast bacteria, for GYN specimens, like I told you, in HPV, but we don't really use it for a lot of other things. Additionally, the same thing for parasites. Even though there's a lot that has been developed, we don't routinely use it because we use our eyes, we use special stain, like just basic special stains, and we use our clinical setting and of course our geographic location to determine our differential diagnosis. So I think that's basic. And what I like again about this table is the cytomorphology and the mimics that it can give us. Okay, let's talk specimen collection a little bit. And I found this from Clinical Microbiology newsletter. And I think the basic thing is whatever you do, however you acquire the specimen, do it sterilely, do it aseptically. And that is going to give you the most yield. And a lot of the times, if I think about my home country in Ecuador, I don't have special media. I don't have special transport fluids or components. So just doing it in sterile saline, in a sterile cup, and in a sterile way changes everything and can give us diagnosis. The other thing, if you fix a cytology specimen, it's of no use for microbiology. So keep it in saline, transport it fast. So I asked Dr. Lear, our microbiologist, well, what are your tips? Well, the first thing he said, collect the sample in a sterile fashion, big and foremost. Then, and that's whether you're doing the sample, whether you're collecting the sample, or it's your clinical team, like they're doing an endoscopy and you're telling them, hey, we need microbiology, make sure they do it aseptically. Then transport rapidly to the lab within 2 hours, or refrigerate the specimen. That's going to make it last at least 12 hours. And why is that important? Because you have bacterial overgrowth. You can use transport media, but like I said, we don't always have it available. So if you don't, use sterile saline. And I asked him about swabs because when I grew up, we used a lot of swabs back home in Ecuador, but here they were like, nope, do not touch the swab, do not use the swab. And it's okay to use the swab, but it's not ideal. If you can, just use the tissue. Or in our case, use the cytology specimen. And always, always communicate with the lab. Whatever you're thinking, write it in that clinical diagnosis and that differential diagnosis, because different organisms require different stains or different media to grow. And those are the references, and I think I'm okay on time.
Thank you so much, Dr. Rosenblum. We have one question in the chat. It's about the test performance of the AFB staining test.
Yes, so that's an amazing question. The yield for us here in the United States in our specimens, very low. Very, very low. The same for GMS and fungal organisms. Do we see them occasionally? Absolutely. However, again, the geographic differentiation of the type of specimen that we get and the type of infection and the degree of the infections is very different, right? So we still have HIV positive patients that are at risk, or immunocompromised patients, but they are usually treated, they have access to healthcare a little bit quicker. And so therefore the yield for these specimens is much, much lower. And so if we're thinking about it, for us, it's key to send to micro as opposed to just do a cytologic diagnosis.
That is a great question, and you could keep it on hold as we move to our next speaker, who will be Mr. Yabio from Ethiopia. If he could even start bringing up his presentation to the presentation slide, I'll share that he has a Bachelor's of Science in Clinical Laboratory Sciences, a Master's of Science in Clinical Laboratory Management, and a PhD in Healthcare Management. And he has more than 10 years of experience in the field in histology, and has had multiple lectures and just educational experiences. And we are grateful to him for sharing some of his educational teachings with us in this next case. And I will come back on camera when it is time for us to start taking questions. Thank you so much. Oh, we can't hear you. We can't hear you, Mr. Yabio. Let's try your audio one more time with the connection.
Hello?
Yes, perfect. Thank you so much. And if you could place it in presentation mode again. Yes, wonderful. Fingers crossed.
Does it come the presentation to you?
Yes, it looks wonderful. Thank you.
Thank you. Thank you very much. Sorry for the happening. Merry Christmas to all attendees, and Merry Christmas to our hosts. Thank you very much for having the opportunity. This presentation is first is an experience. Second, to share what is the current practice in Ethiopia for the importance of implementing diagnosis of pulmonary TB. It an experience, and I will try my best to finish within 10 minutes of time. And let me start with this slide. It is the current cytopathology stains or right stain for age 23 from axillary lymph node. Just since we are discussing about the staining and the diagnosis method of currently what we use for diagnosis of extrapulmonary TB, I choose extrapulmonary TB because it is increasing from day to day, year to year, and is a great public health problem in Ethiopia. When we see the routine diagnosis of the current diagnosis, you see in most TB prevalent countries like Ethiopia, Cytology uses for diagnostic tool for the diagnosis of TB lymphadenitis. Dr. Freda's presentation was really interesting and connected with what just want to plan to implement to make supplement diagnosis for the country Ethiopia. We have never seen diff week, for instance, in Ethiopian experience, but routinely diff week and Papa Nicolai stain and can be done for fine respiration pathology of lymphadentic TB, even low and middle income countries. In different literature shows that it is better to use lymphadenitis method of diagnosis like cell gene expert and different like immunocytochemistry and different methods. And this is for the introduction purpose to show you how the burden, the prevalence of TB, external pulmonary TB in the world, as well as in Ethiopia, as well as in the continent Africa. WHO reported in 2020 5.8 million newly diagnosed TB. 2020, that took back to the level of 2012 because of the COVID and something epidemic that increases. The report added 30 high MDR reactive TB burden countries. Ethiopia is one of them, but now it is transitioned to out of the list. But these countries like Mongolia, Nepal, and Zambia are joining for 30 high burden of the TB. And Ethiopia is the third top country affected by external pulmonary TB globally. And Ethiopia is high tuberculosis burden country, for shows that it is one of the highest incidence rates in external pulmonary TB that the data shows. And is the country Ethiopia, the map shows that all these numbers show that there is pulmonary TB in percentage 44, 26. These are the regions divided by the governmental regions. These, for instance, 40, 60, almost average is about 40 or something like that, 30 something. So it is the burden that only external pulmonary TB that we it is shown here from EPHI, this Ethiopian Institute for country now. This from Hawassa. This Hawassa is the southern part of Ethiopia. This study show is in 2015. TB lymphadenitis shows this table. So let us hear the burden, how the productive age here. The productive age is 40.5. For productive age is in extrapulmonary TB. So when we see the ratio male to female 1 to 1.15. So let us see also this one. From the Gondar. Gondar is the northern part of Ethiopia. The 5 years retrospective data were collected from the University of Gondar Department of Anatomy and Pathology, and there are 3,440 aspirations were done. 1,392% is TB lymphadenitis. This is too much, this huge number. When we classify male to female, is the male is 1647 and the female is 1793. See, what we emphasize in this case that female is highly responsible for home, the social communication, home and children, so she can have high responsibility in social and home for children and other social responsibilities. And the study again from Gondar is the productive age is 70.6 from the total of the diagnosed TB lymphadenitis. Now, there are unpublished data that I was working with in the public hospitals. So the same number is repeated that shows productive age highly affected with external pulmonary TB that mostly affected cervical lymph node. And is a technique that shows how the final aspiration is collected. And it is the current what we use for right stain or GEMSA stain. One of them we use Orpose. We use this, the first slide shows this slide is collected from female gender with the age of 23 from axillary lymph node. This one I found from one study paper. It's very interesting. This immunocytochemical staining for lymph node aspirates. This immunocytochemical staining shows that this red color you can see is diagnosis of positive for TB. So if this is almost luxurious for the country where only right stain can use, but when we see the actual diagnosis important for external pulmonary TB, this is a very important and a supplement method for diagnosis. And the routine method of diagnosis is this is what we discussed in the first slide. When we conclude my presentation, training on receiving and staining methods of samples from lymph node is highly required in histology laboratory in Ethiopia. It is highly recommended to use at least 2 types of staining methods, like Diff-Quick rice stain, for instance, or Zielensen rice stain, for instance, is recommended. And this is required support, training, and awareness. Most of the problem is the logistics. Availability or logistics and quality staining reagents should be revised, and the standard guideline should be prepared and distributed to all institutions so as to make uniform the practice in all the nations.
Wonderful. Thank you so much, Mr. Yabio.
Thank you.
I do not see any open questions in the chat. If anyone has questions, please place them in the Q&A area. And so then, do you use routinely the immunocytochemical, the ICC stain for TB? Or do you use the kind of AFB stains? I'm just curious. The example you showed was of the ICC, and I'm wondering how frequently you use it in your laboratory. Oh, I'm sorry, we can't hear you again. And I may open this to the other panelists too to see what their thoughts are.
I think you can hear it now.
Yes, now this is perfect.
Thank you. Thank you. I think it interrupted frequently. You see, we have never seen immunocytochemistry in case of cytology studies in Ethiopia.
Got it.
And mostly it is it uses either GEMSA or red stain for diagnosis of cytological cases. But we need that at least Diff-Quick is introduced. At least Diffquick and Jensen is introduced. And besides, pap smear also introduced. We recommend that, but we didn't use recently, and we have never seen. It is luxurious almost here.
Could you point out what you're looking for with your Diffquick stain on your slides for the audience? Are you
We
able?
need,
Mhm.
yeah, we want to introduce Diffquick for every, especially in the public institutions. We want to introduce Diffquick, how important it is for diagnosis, and it is a supplement for diagnosis like bright stain, stain, especially for illness, and they will use if it's affected on the specimen.
And if you even make this picture bigger for us, if you go back to the presentation mode or even zoom in, what are you looking for? Because I know this is a case example, but it when you are performing, do you perform the fine needle aspirations yourself, or do you work with a colleague for doing them?
No, my professional expertise doesn't allow to collect final aspiration, but I just want to receive the sample and staining accordingly. What is the best for this sample?
And then what of these in this image, what is making you suspect that it could be extrapulmonary TB as the diagnosis?
I just selected randomly, but to show only how the right stain looks like. Only I just present this slide to show you how specific stain using in the country.
Great. Yes, Dr. Rosenblum, do you want to?
Yes, so from we don't get a lot of cases obviously here, but I do know that if you do a Diffquick, obviously it doesn't highlight the organisms, it's actually a negative image. So you see kind of the empty rod space that if you're like super keen to it, you will think of extrapulmonary TB or other organisms. So it will be a blank or white empty space in the Diffquick, as opposed to highlighting really the organism like an cytochemical stain will do. And there is a question on the Q&A that I can say just a little bit of. So the question is, kindly point out any experience with auramine stain or gene expert. And so for the auramine rhodamine stain, it's very technically difficult. It's a fluorescent stain. That's also important to remember. So again, you need extra like a fluorescent scope, and you have to be very technically savvy. So it's very technically complicated. It's less and less commonly used now that we have molecular analysis and P16 analysis, and Dr. Milner can definitely chime in if I'm saying something crazy. But so here in the US, our experience is kind of going down with auramine rhodamine because we have additional panels that we can use like molecular that is more readily accessible to us. Yes.
Thank you. Anyone else from the panel have other comments to add on that? And I guess the main thing that I always think of is TB is really small. It's very small, and it's not even always obviously within one plane of focus in cytology. That's the most important part, is that even in a histology section that's 4 microns thick, you sometimes need to focus up and down to try and find these organisms. So it takes a really long time to even go through a small section. When I'm looking on we do AFB stains at my institution, and I feel like I have to very systematically, just like we're screening a cytology smear, go through all of the sections and focus up and down for each field to be sure that I'm not seeing any little squiggly things in the different planes. It's kind of like looking for H. pylori in some ways as well, just looking for those small organisms, and they may be very infrequent in number. So there might not be very many of them. So it is quite tedious, which is why having something like an immunocytochemical or a fluorescence stain, if the performance is good, can help highlight those very small organisms. Thank you so much, Mr. Yabio, for your presentation. We will move on to our next case now, and then hope there will be some time in the end if there are other questions that come up. So I would now like to introduce Dr. Mahari from Ethiopia. Mr. Yabio, if you could unshare your screen, and then Dr. Mahari can then start to share hers as well. Great, wonderful. She earned her MD degree from RC University and also a master's in general public health from Diridawa University. And currently she is finishing her second year of residency in anatomic pathology at St. Paul's Hospital Millennium Medical College. She has a special interest in cytopathology and also gastrointestinal pathology. So we're very excited to have her speak to us today. Thank you so much, Dr. Mahari.
Okay, thank you. I will be continuing with our case presentation on cutaneous leishmaniasis. Since our time is very limited, I will try to focus on the most pertinent points. So the patient was an 18-year-old male patient who resides in one of Ethiopia's city in which leishmaniasis is endemic. He came with skin ulcerations of 6 months, and the ulceration started as a small nodule, which gradually increased in size, causing a non-healing wound. On physical examination, there was 5 by 4 centimeter ulcerated lesion over the dorsum of the right hand with raised edges and central crater. There was also separate 1 by 1 centimeter crested over the proximal right forearm. Cytology and pathology. This is done from skin scraping, and you can see that it is infiltrated by mixed inflammatory cells, and the predominating cells were histiocytes. Within the cytoplasm of the histiocyte, there were these small intracytoplasm. This is an immersion. In this picture, you can see that the organelles have well-rounded cytoplasmic membrane, central nucleus. In addition to that, they also have a rod-shaped kinetoplast, which is identifying for leishmaniasis. Taking you back to the 40X, you can easily appreciate that most of the histiocytes were infiltrated by these small intracytoplasmic organisms. This is the punch biopsy from the similar site. There was a deep dermal chronic inflammatory cell infiltrate. Most of the cells were histiocytes, histiocytes, plasma cells, and lymphocytes. There were also focal areas showing eosinophils. There were also well-formed epithelioid granulomas, which were cuffed by lymphocytes, and they were mixed with Langerhans type giant cells. As Dr. George said, TB is very common in our setup, and it's very easy to misdiagnose these patients as a TB. So this is a high power field, and this is why patients suspected to have cutaneous leishmaniasis, the slides have to be scanned on 14X. And in these slides, you can see that the cytoplasms of the histiocytes and the empty spaces are infiltrated by pale blue staining tiny organisms. They look like a histoplasmosis, but unlike to histoplasmosis, these do not show budding. And in addition to that, it's very difficult to appreciate the kinetoplast on a high power field of a biopsy. But in addition, unlike to the histoplasmosis, they tend to aggregate around the periphery of the cytoplasm in the So with this, the final diagnosis was cutaneous leishmaniasis. So leishmaniasis refers to various clinical syndromes caused by an obligate intracellular protozoa. It was independently reported in 1903 by Sir William Leishman and Charles Donovan, whose names are currently being used to describe the intracellular stage of the parasite. Worldwide, 98 countries and territories are endemic for leishmaniasis, and an estimated 1.2 million new cases and up to 30,000 cases occur annually. So majority of are the countries that are around the tropics in Africa, Middle East, Central and South America are affected by this disease. In our country, Ethiopia, cutaneous leishmaniasis was well known since 1903, and per year we tend to see 50,000 cases. So the parasite has two hosts to complete its life cycle, which includes the humans and other vertebrates. It includes up to 70 types of vertebrates. And the second is the most important vector, phlebotomine sandflies. And it has two developmental stages. The first is the promastigote, which is the flagellated form. It is seen within the gut of the sandfly. You cannot see it on humans, but it can be grown in a culture in limited setups. And the second is the amastigote. It is a round organism with average lengths of 2 to 4 micrometer. It's defined by a well-delineated cytoplasm, a nucleus, and a core or rod-shaped kinetoblast. Some pathologists refer this as a dot and a dash, a dot for the nucleus and the dash for a kinetoblast. This picture is from the CDC. So the life cycle of this illness begins with the sandfly injecting the promastigote into the skin. It is then engulfed by a macrophage, and it's transformed into an amastigote stage. Amastigote stage multiplies within the macrophage, and it is then later taken by the sandfly. Within the midgut of the sandfly, the amastigotes transform into promastigote, and the life cycle continues. So the vector is a female phlebotomine sandfly. It's a very tiny insect, which is much smaller than the normal mosquito. The average length is 2 to 3 millimeters. It tends to live around the tropics. It is easily identified in acacia trees, in the dust, in holes, and even in the ponds. Often they tend to bite their hostess during the dusk and the downtime, leaving a painful lesion. So other rare forms of transmission, case reports have been written on leishmaniasis transmission, on blood transfusion, contaminated instruments, and also congenital. So generally, types of leishmaniasis includes cutaneous leishmaniasis, which is the most benign form and the most common form. Up to 75% of patients present with cutaneous leishmaniasis. And the second and the most disfiguring is mucocutaneous leishmaniasis. It leaves a really bad scar, leaving it permanently. And the most severe is the visceral leishmaniasis. It causes days of its patients if left untreated. So cutaneous leishmaniasis is an infection of the skin macrophage. Patients commonly present with chronic nodules or ulcers, and these lesions usually heal spontaneously. The nodules are seen within weeks to months after the bite of the sandfly, and of course, they appear on the parts of the body which are exposed to the sandfly bite. In a single patient, multiple lesions can occur. Up to 200 lesions have been recorded to have occurred in a single patient. And that's not because they tend to disseminate, rather, it's because of multiple sandfly bites. These are commonly seen species in Old World and New World. So how do we investigate and detect the parasite? There are many serologic tests, but the most important is staining, is visualizing the organism under microscope, and more than 70% of cutaneous leishmaniasis cases, Giemsa stain and histologic sections reveal the presence of the parasites, which is diagnostic. So another most important thing to take home is that it should be noted that dermal scrapings, needle aspirations, and biopsies should be taken from the raised edges of the active lesion, because that's where the parasites reside. And taking samples from the central necrotic area should be avoided, because obviously the aspirate will be non-revealing. The only thing you will see is chronic inflammatory cells, a granuloma, and only non-diagnostic findings. So the closest differential diagnosis for leishmaniasis are histoplasmosis, emperipolesis, and granulomatous disease. So these are my references, and thank you.
Wonderful. Thank you so much for that really informative talk, Dr. Mahari. One question in the chat is, well, a comment is that they recently encountered a visceral Leishmaniasis case. That is, yes, very striking. And there is a reference also that's placed in the chat as well. And I am curious, have you encountered some of these cases yet, Dr. Mahari? Oh,
Yes, this is the patient we diagnosed.
and have you then actually performed the scraping yourself?
Yeah, with the assistance of Dr. Barakat, he taught us how to do it.
And can you tell me a little more even about how much scraping do you do? Do you use like I would think, because I actually have not done any of these scrapings myself. I've only done fine needle aspirations, and those have liquid that definitely comes from it. I would think a cutaneous scraping, I don't know how moist or not the lesion may be, especially at the periphery, as you suggested, to scrape in that area. So I'm curious if there is any, like you have to get something wet. How do you get it to stick on the slide in some ways? I don't know if Dr. Barakat or Dr. Mahari, yes, if you'd like to just share about your experience performing the actual obtaining a specimen.
Well, it's going to be painful for the patient, but we can take a surgical blade and do the scrapings. Then, like you do with a needle, you take the scrapings with the blade and you smear it on a slide. That's stained with GIMSA and it's easily visualized.
Okay, and then
for this particular patient, yeah, we took 2 scrapings and 3 slides.
And the scraping, it's still pretty superficial, though. You're really just scraping along the surface of the skin, not cutting in at all. And
yeah, but you can also take a slit skin test but before the blood starts to come out, you can take the samples.
Can you describe more of this slit skin space? I am curious more. So is that making an incision then into the skin?
Yeah. Yes, a superficial skin incision can be done using a blade. Then before the blood starts flooding, you have to take another clean slide and put it on the wound. Then the slide can be used to be smeared.
Got it.
And also clinical setups, they also take the blood and they mix it with normal saline. It can be centrifuged, and the centrifuge can also be used to be evaluated for cytology.
Got it. In a way that a cell block may be used, right? Got it.
Yeah, like a cell block, just like a cell block, you can use it for cytologic analysis, staining it with GIMSA.
I am learning so much. This is wonderful. There are actually 2 great questions also in the chat. So the first one is about the actual performance of the biopsy. So when you do the scraping, is there any anesthesia that you give? Do you do a lidocaine spray? Will that disrupt the specimen, or do you just scrape directly without any anesthesia?
We just do the scraping because the pain is similar. It's both are needles, and by the time you give the anesthesia, you are done taking the samples. So we do it without any lidocaine.
Got it. So no lidocaine. And then is that similar for the slit sample?
Yes. But you have to inform the patient that it's going to be painful.
Yeah.
And after that, we can do, it's just a superficial incision.
Mm-hmm. Got it. And thank you so much. One other question, is there any difficulty in distinguishing cutaneous Leishmaniasis from other granulomatous dermatitis. I would think that would be difficult, actually, more because you have that inflammatory reaction, and it's really up to us to try and find the organisms. Do you, I think, tend to see frequent organisms with the Leishmaniasis? Is it almost all of the macrophages should have the organisms inside, or is it sporadic that some will have it and some may not?
Well, that depends on the stage of the ulcer. If it's an acute wound, majority of the macrophages tend to have the parasite within them, but you have to have a high index of suspicion, and you have to know where your patient resides, because in our city in Addis Ababa, it's not very common to see Leishmaniasis. So the first thing we do is ask where the patient came from. Then, with a high index of suspicion in acute ulcers, majority of the macrophages are filled with the amastigotes. But if it's chronic, identifying the parasites is very difficult. And with high power, every part of the slide has to be scanned.
Mm-hmm.
Otherwise, in a setup like ours, where TB is very common, it's very common to misdiagnose these lesions are tuberculosis.
Mm-hmm. I could see
because
that.
both lesions cause similar granulomas and giant cells.
I could see how they could be very, very similar, right? In just like the components that you see on a sample. I do not see any other questions in the chat. I am curious whether any of you have questions for each other.
I do have a question for the group. In the States, just like anywhere else, when we're trying to have the gold standard, right, for proving TB is obviously culture or the molecular analyses with the extended time frame. So in locations where TB is endemic, then can some of the panelists describe the clinical approach, the management, right? At which point does the team decide to treat the patient presumptively, right? As you're waiting for those results. You know, obviously a lot of it has to do with the clinical presentation and the findings, the cytologic findings, but can some of the panelists comment on that aspect?
Yes, please, Dr. Barakat, if you could share, that would be wonderful.
Good afternoon, everyone. Is my voice clear?
It's great.
Can you hear me?
Perfect. Yes, we can hear you well. Thank you so much.
Speaking without video, I think that's a good question. In fact, that's one of our biggest dilemmas. Several researches have been done, and the fear is, at least in our Ethiopian context, I have seen it in Gondar and at St. Paul and all the tertiary level institutes. We do research and research, and still I think we are overdiagnosing TB lymphadenitis. As George said, what we base our diagnosis morphologically. We look for three things: a caseous background, granulomas, giant cells, a mix of them. And then for this one, we say consistent with TB, meaning a trial of anti-TB can be started, which is a 6 months treatment. So we comment and tell them to follow the patient closely. That is for 1 month to 2 months to see whether there is any change in the lesion, in size, and so on. For those that have equivocal morphologic appearance, like a caseous background only or granuloma only, wherever there is available, we do a gene expert. And if gene expert, most of the time it returns back negatively, but for those who are positive, we advise the clinicians to start anti-TB. As things stand, we don't have the molecular techniques for further diagnosis, and I was not aware of George's experience at the International Clinical Laboratory, where they did with a trial with immunohistochemistry, and I would have liked to hear more about that, or whether he can share his observations on that.
Thank you so much for sharing. I do wonder, how long does it take for the gene expert results to come?
At St. Paul, where Hewitt and me are based, it takes from 3 days,
24
sometimes
hours.
yeah, on the diligence of the responsible technician. But I would say usually within 48 hours, they give us the result.
And then what is the material that you send for the testing, for the gene expert testing?
Pass would be the ideal one. Pass at least around 1 ml. That's what the optimal they say, but we aspirate pass when it's like a fluctuant lymphadenitis. Otherwise, we just aspirate whatever we can and can't eat on the test tube and send it. But ideally, pass.
So it really is a fresh sample that you're sending. And so then if you want to send a gene expert, then you must see the patient again. Is that what it is? To see the patient again to then do a re-aspiration? If you decide to send it because they have not responded potentially to treatment?
We don't have this rapid on-site assessment, ROS, as a practice. We have not instituted it. So what we do is we look at the slides, and if they are equivocal, like I said, only cases background, not fulfilling the 3 morphology criteria, the patient is supposed to come back the next day to pick up his results. So we do another needling and send the sample immediately to the clinical laboratory on the next day.
Got it. That's wonderful. Great question and great answer. Any other questions or thoughts that folks want to share?
Let me elaborate Dr. Barakat's explanation. You hear me?
Yes.
Okay. It's a very good explanation from Dr. Barakat. As far as I understand, and I know that this setup clinical laboratory in Ethiopia shows that only ERPR in HER2 from breast cancer immunohistochemistry is done, not only immunohistochemistry.
You're a little quiet, George. Could you speak up a little more or go closer to the microphone? Yes. Oh no, now you're gone. I can't hear you anymore.
You know? Working?
A little quiet still. Yes.
No. What about now?
Better.
Working?
Yes.
Working? Thank you. Thank you, Dr. Barakat, for his explanation. Is a very elaborated the case and the how important diagnosis for just follow up for the patient. And for me, as far as I know, only immunohistochemistry for breast cancer is done in the best setup laboratory, diagnostic laboratory in Ethiopia, but no immunohistochemistry experienced in Ethiopia, as far as I know, in the practice where I practice in most advanced setups.
Thank you so much, Mr. Yabio. Yes, it is a limited resource, the immunocytochemistry and immunohistochemistry. Anything else to share from the group or thoughts? Yes, Dr. Rosenblum.
I had a question for the group about multi-drug resistant and drug resistant TB and how that is like affecting your practice.
And I guess in some ways, part of the question is, if a lot of it is morphology only, then we may not know what the phenotype of the organisms are and whether or not they may be susceptible to the standard treatment regimen. And how does that get figured out?
Yeah.
Please, Dr. Barakat.
Again, this is also a sort of twilight zone, very blurred the only centers that have the reliable center for doing multi-drug resistance. One is adjacent to St. Paul at the Ethiopian Public Health Institute, and another one is a well-known center, the Ahari Center, and we sent them, and they have the good microbiological facilities where they do multi-drug resistance, and only a minority. We did a recent study. I can share it with the group tomorrow at St. Paul of a 6 months prospective study where we did all the available tests, that is morphological diagnosis, following up with gene expert for all the cases in this case, and doing multi-drug resistance. And if I'm not mistaken, it's only around 5% or so it showed the multi-drug resistance. They do it for rifampicin and isoniazid. And then based on the protocol adopted from the WHO, they start them on the long-term regimen, which is quite expensive and also quite asking for the patients. It's, I think, an 18 months long regimen. But as I said, we don't have a clear picture of the burden of these multi-drug resistant strains, especially in lymph nodes.
Thank you so much. It's good to know it's only 5%, but it's hard to know how that may be changing, right, over time. So that is great insight. I think if there are no other questions, then I may close this session and really thank our speakers for their wonderful presentations. And thank you for all the education that you shared with me and hopefully with all of our learners. I think if there are other questions that folks have, that there may be a mechanism for feedback that we will be sending out. So we'll send out a survey and it'll be attached, I think maybe to something that we send to the group about how we may improve the sessions. And then if there are any feedback that you have for this session, as well as there are any suggestions or requests for future topics that we can discuss. We will continue to have the cytology sessions, the didactic sessions over the next few months, and we will have one more cytology echo within our kind of year-long education that will be in April of next year. And so we really do hope to encourage more participation and great questions for topics. Thank you so much, everyone, for participating in this session. All right, bye.